Hello there, it's Luke, and in this tutorial we're going to be considering obstructive shock, and we're going to be thinking about the physiological mechanisms that lead to the signs that you may see in patients with obstructive shock. So, excuse me, here we go. So you'll recall from our previous tutorial that we've got broadly 4 categories of shock. Shock being that failure of getting nutrients and oxygen to the tissues and getting rid of all the toxins and carbon dioxide away from the tissues. And in this tutorial, we're going to be thinking about obstructive shock, whereby the pump is blocked somehow. And there are 3 sort of main causes that might give you an obstructive shock. There's cardiac tamponade, where the heart is being compressed by fluid surrounding the heart. There's a tension pneumothorax, where there's air trapped within the thorax, but outside the lung, and that's compressing all the structures within the chest. And then there's pulmonary embolism, which is where you get blood clots forming within the pulmonary circulation. So if we think first of all about cardiac tamponade, so you're no doubt aware that your heart sits within something called the pericardial sac, and this is made up of layers. And these surround the heart, they protect the heart. So on the outside of it, there's something called the fibrous pericardium, which is very tough, as the name suggests. And this both anchors the heart in the right position, prevents it from overstretching, and protects the heart. And then beneath this, we've got this layer of fluid within the pericardial cavity. So there's like two layers of tissue, if you like, and this layer of fluid between them. And this helps the heart can move within that sac while it sort of contracts. Now, if for whatever reason that fluid builds up, because the fibrous outer layer of the pericardial sac doesn't really stretch a great deal, that fluid then can begin to compress the heart. And what we find is that actually it often compresses the sort of right side of the heart, which is sort of less muscular. Now, that fluid can build up there because there's inflammation, and we refer to this as pericarditis, and there are some cancers that can cause this, there's some infections that can cause this, or even in the context of trauma, or especially cardiac surgery, you can get blood within that space, and that can also, so this is blood outside of the heart's chambers itself that is compressing, like I say, mainly the right side of the heart and preventing the heart from beating well. Now, with this cardiac tamponade type of shock, you get a big drop in blood pressure and a raise in heart rate. Now, the drop in blood pressure comes about because the right side of the heart is being compressed, so less blood can get back into the heart. And so if there's less blood entering the right side, there's going to be less pump through to the left side, and the left ventricle is going to be less stretched. So it's going to be less preload. It's not going to be beating as effectively, and we'll get a drop in blood pressure for that reason. And this is what I've just explained, sorry. So we've got our Frank-Starling relationship here. So the more full the left ventricle is, the greater the force of contraction and the stroke volume. And with this type of shock, actually, we're right down here, and we'd want to be up here, so a nice full ventricle beating well. Now, because there's obstruction, there's pressure preventing blood travelling through the right side of the heart, you get back pressure building up, and you may see on this photograph you've got distended jugular veins, and that can be a feature of cardiac tamponade. Now, the tachycardia, it relates to the autonomic baroreceptor reflex. So you'll recall that there are stretch receptors within the aorta and the carotid sinus, and these send messages up to the medulla oblongata, and based on that impulse and other information, there's then efferent nervous impulses to various effector organs, including the heart. And if the blood pressure is low, then there are fewer, or rather less frequent, vagal impulses to the heart. And you recall the vagus nerve acts like a brake on the heart. So if you're not pressing as hard on that brake, then the heart rate will go faster and you'll get the tachycardia. Now, because you've got this drop in blood pressure and the autonomic nervous system is involved, you will get vasoconstriction as the nerves encourage the blood vessels to constrict, but also the nervous impulse to the adrenal glands will cause circulating adrenaline and noradrenaline, and also there'll be release of angiotensin too eventually. Although that's probably got less of a role to play in this instance. And all of these things constrict the blood vessels so that the blood is away from the peripheries and towards the heart and the vital organs. And because it's away from the peripheries, your peripheries will feel colder and your refill time will be prolonged. The second type of obstructive shock that we're going to talk about is tension pneumothorax. So that's air that has somehow, generally through sort of injury or a weakness in the pleura, which is the sort of lining of the lungs, has found itself within the chest but outside of the lungs. And there's almost a sort of one-way valve where the air can get in and compress everything within the chest, but it can't get back out of this little sort of weakness within the pleura. And this can occur for a number of reasons. It can occur spontaneously in asthmatic patients, for instance. It can occur due to trauma. Unfortunately, when we use mechanical ventilation, so ventilators, we can damage the lungs. And also when we're performing procedures around the chest, we can injure the pleura which surround the lung and bring about a tension pneumothorax at that point as well. And here is a chest x-ray image. So on the left-hand side of the chest, so this is the left, this is the right, on chest x-ray, there is this big empty black space where there's just air inside the chest. And we can see that the left lung and the heart and even the trachea, which is this sort of darker area here, are all being compressed over onto the right side. And one of the other things that is being compressed is the blood vessels within it, and they're being sort of pulled and torted and twisted. And so the flow through those blood vessels, especially the flow through the vena cava, is reduced. So here are the signs and symptoms that you may see with somebody with a tension pneumothorax. So as we just pointed out on that x-ray, there's tracheal deviation, things move into the side away from where all the air is gathering. You may hear reduced lung sounds, and you have this hyper-resonant, high-pitched sound when you're percussing, and then you'll have this rapid drop-off in blood pressure because all those blood vessels are being sort of squeezed and squashed. There's no flow through the vena cava, or less flow through the vena cava, which would of course mean less flow back to the heart, through the heart, and to the left ventricle, and so less preload, and so we'll have a drop-off in our blood pressure. Now, because those blood vessels are being squeezed and sort of obstructed, as the name would suggest, the flow of blood from other parts of the body, including the sort of head and neck, is inhibited, and so you'll get the veins may become very engorged, and that's, as with a lot of these sort of obstructive shock types, you may get engorgement of the jugular veins. That may be something that you'll be able to see. The third type of obstructive shock that we're going to talk about is pulmonary embolism. And this is a thrombus forming in the pulmonary arteries. And it can be one big thrombus, a saddle thrombus, for instance, that sort of sits in the main part of the pulmonary artery and obstructs the flow to both lungs. Or it may be lots of little sort of clots throughout the lungs that increase the resistance against which the right side of the heart has to beat. And pulmonary embolisms are sort of graded in part by how they affect your blood pressure. So if you're systolic, so the top blood pressure number drops below 90 millimeters of mercury, this is by definition a massive PE and needs urgent treatment. So as you would expect with somebody with blood clots in the vessels of their lungs, you have respiratory distress, maybe increased work of breathing. You'll have increased heart rate, trying to compensate for that drop in blood pressure. Cyanosis, because there's not so much oxygen getting into the blood. And again, those elevated neck veins that we were talking about earlier on. So why is that? Well, here's a diagram of the heart, and here are the structures on the right side of the heart. So right atrium, right ventricle, here's the pulmonary artery. And if we've got clots, and again, this is an oversimplified diagram, sat in the pulmonary artery, actually, you'll recall we talked about a thing called afterload, which is the pressure that a ventricle must overcome in order to open the aortic valve on the left side of the heart, or the pulmonary valve on the right side of the heart. Now, bear in mind, there's not a lot of muscle in the right side of the heart, so the right side of the heart can fail fairly easily if you've got a huge clot sat in the pulmonary arteries. And so you have two things going on at once in this sort of obstructive shock. You have a failure of blood coming back to the heart because there's this sort of blockage and increase in pressure, and it's a very low pressure system that you have on the sort of venous side of things. So there's less blood being pumped through the heart because there's this blockage in the pulmonary circulation. So there's less blood getting to the left side of the heart, less preload, less stroke volume, less blood pressure. But also you might have the right ventricle failing because it's not very muscular. It can't generate a lot of force. And if you've got a big clot, that is meaning that the right ventricle has to generate more force that it just cannot do. Then you also get sort of failure of that right side of the heart. And again, common with the other sorts of obstructive shock that we're talking about, you may get distension of the jugular veins for this reason. So in summary, there are three main causes of obstructive shock. They're pulmonary embolism, cardiac tamponade, and tension pneumothorax. Each of these inhibit the flow of blood to the left ventricle and therefore reduce preload and stroke volume. They all cause respiratory distress and hypoxia and can cause an elevation of the jugular venous pulse, so this distended neck veins that we talked about. A massive pulmonary embolism can increase the right ventricular afterload, so the pressure that it must overcome to eject blood into the pulmonary arteries and cause the right side of the heart to fail. Thank you very much for listening to this.